Hello, my name is Jane Apperley and I work at Imperial College in London. And today I want to talk to you about the difficulties and challenges around maintaining the ability to have children in women who have chronic myeloid leukemia. These are my disclosures, and while you're looking at those, which will come as no surprise, I think, I want to explain that I completely understand that around the world, we all have different access to the various drugs and to various levels of sophisticated monitoring. We are fortunate in the UK that we have access to all 6 drugs at the moment, and we also have access to very good molecular monitoring. So the scenarios I'm going to present to you are, if you like, the scenarios you may visit and the decisions you may have to make in an ideal world. So I want to start with a patient, and this was a woman who was diagnosed with CML in chronic phase in 2014. She's 35 at the time of diagnosis, which is obviously a slightly difficult age for a woman who has no children, but expresses a desire to have a child, because we all know that in the mid-30s, we all start to worry about the biological clock. She's a relatively straightforward patient. There are no additional chromosomal abnormalities, and her UTOS long-term survival score was intermediate. It's important, I think, to remember that discussions about parenting children really have to start at diagnosis, and this includes both men and women. It's important to understand the patient's situation at that time and what they would like in the future. And to be able to have these discussions properly, you have to know the impact of the disease, the phase of the disease, and any treatment you might give on the fertility and potential pregnancy of any woman or partner of a man. You need to know this because it may influence your choice of treatment, and it may influence the strategies you use to maintain the options for parenting children. And what do I mean by that? Well, in chronic phase, in young women who want to have children, you might think about using a more potent drug, a second generation TKI, perhaps in the future, third generation TKI, frontline, so that you induce deep responses as rapidly as possible, which gives you the ability perhaps to stop treatment for pregnancy rather earlier than you would do if you used imatinib at diagnosis. I'm not going to talk very much about men, but in men who are in advanced phase of presentation where transplant is a real option for them, you may want to talk about semen cryopreservation, and similarly in women who present in advanced phase and may well be going to transplant, discuss the possible options for them with your local IVF unit. So to talk about ovarian, oocyte or embryo cryopreservation once the woman has been established in the second chronic phase. Now, the drug companies, as you probably know, are obliged in the development of the drugs to look at the impact of any new agent on fertility and on pregnancy. And so you'll find in the investigators' brochures and in manufacturers' recommendations that for all 6 drugs available to us, there did not appear to be effect on fertility, i.e. the ability to become pregnant in female animals, and we're talking about mice, rats and rabbits, at any of the doses that you would normally give a patient in the clinic. But when you give any of the drugs to pregnant animals, they did cause death of the litter once the doses started to go up, and you see very consistent abnormalities of the skeleton, the brain, the gastrointestinal tract and kidneys. And these are thought to be, at least in large part, due to the inhibition of one of the other tyrosine kinases, which are the platelet-derived growth factor receptor alpha. And the sort of abnormalities you see are horseshoe kidney, malrotation of the intestine, and occasionally exomphaseal, which is when the intestine is exposed on the abdominal wall, poor formation of the vertebrae with hemivertebrae or fused hemivertebrae, and also, unfortunately, neural tube defects so that the infants can have anencephaly right through to spina bifida. Now, these abnormalities were seen much more frequently in the early days, largely with imatinib, when imatinib was the only drug, and we weren't so conscious of the fact that they might induce congenital malformations in any infant. The women who were on imatinib early on in the days of imatinib were advised not to become pregnant, but humans are humans and things happen. So we published a long time ago now, 15 years ago, together with colleagues from Novartis, what happened to 125 women who became pregnant on imatinib and in whom we knew the eventual outcome of the pregnancy. Now, the great majority stopped the imatinib as soon as they discovered they were pregnant, and many of them in the early days elected to terminate the pregnancy because they were so unsure of the outcome. So of those patients in whom we knew the outcome, 14% had spontaneous abortions, which is actually about the same rate as a healthy population not on any drugs. So it wasn't really felt that the abortion rate was higher, or if it wasn't significantly higher. And 50% went on to have live births. But 9% of the children who were born had congenital abnormalities that were similar to those seen in the animal studies. And as time went on, it became rather more clear and logical, of course, that these abnormalities were occurring if the infant, the fetus, was exposed during organogenesis, which is largely in the first and early part of the second trimester. Now, the knowledge that the drugs caused abnormalities then tempered what happened on subsequent drugs, because everybody was much more conscious about warning women not to become pregnant. So the experience on subsequent drugs is much, much more limited. So for dasatinib, there were 78 pregnancies reported to the pharmacovigilance group within Bristol Myers Squibb, but we knew the outcome for only 46 of those. And you can see in the smaller print, again, about half of them resulted in live births. Many elected to terminate the pregnancy. But of those who went on to a full-term pregnancy, you can see that there was a 15% incidence of congenital abnormalities, some identified at birth and some after elective termination. The difficult thing with dasatinib is that there were 2 instances of hydrops fatalis, which we'd never seen on imatinib. And although you can't completely attribute it to dasatinib, 2 instances in a relatively small number of pregnancies is really worrying. And what was more worrying is that one of these infants was affected when the dasatinib was started in the second trimester. So we're very worried about using dasatinib and perhaps also bosutinib at any point in the pregnancy. There were 50 pregnancies reported on nilotinib, and again, there was a small incidence of the congenital abnormalities, similar to those that we'd seen on imatinib and dasatinib, and then much less experience on bosutinib, where we only know about 6 live births, 5 of those discontinuing very early in the pregnancy. There's virtually nothing on ponatinib, and we now know about 12 pregnancies on asciminib much earlier in development. So again, the elective abortion rate very high, as nobody could predict the outcome. So let's go back to Our Lady. So because she was 35, she definitely wanted to have children. We started her on dasatinib at 100 milligrams daily to optimize the chance of her getting a good response. And now she's going to have 3 different pathways, all obviously invented, but just to illustrate the sort of choices we have to make. So in the first situation, she achieves all the ELN milestones. In fact, she overachieves. She's in CCYR at 3 months, MMR at 6 months, and MR4 at 12 months. And then she becomes undetectable down to sensitivity of 10 to the minus 5 at 18 months. She has some problems with the dasatinib with a skin rash, but we reduce it to 50 milligrams daily, and she maintains her MR5. So for this patient, I would feel very comfortable treating her as she was a patient who was destined for a trial of discontinuation for treatment-free remission. So I'd like her to be in MR4 for at least 2 years, perhaps, and then I would think about stopping the dasatinib and seeing how we get on. So we would monitor her as for TFR with 6 weekly RT-qPCR, and as you can predict, there might be 3 different outcomes. She doesn't lose her MMR, she can stay off her TKI indefinitely, and she can attempt to become pregnant by natural means. She can become pregnant but lose the MMR, in which case we would recommend that she stayed off the TKI until delivery and manage as for a patient presenting in pregnancy, only giving treatment if it was required because of a rising RQ-PCR or rapidly rising RQ-PCR, loss of complete cytogenetic response or loss of hematological response. If she's not pregnant and she loses the MMR within the first 6 months, as we know, 90% of the patients destined to lose their molecular response do so in the first 6 months after discontinuation, we would just recommence the tyrosine kinase inhibitor. Now let's look at that scenario in a little bit more detail. So she was an excellent responder, but she lost MMR within 6 months of stopping. She's not pregnant. We could simply restart the dasatinib at the same dose as she stopped, re-establish her MR4 and try a bit later, restart it at a higher dose, re-establish MR4 and try later. We could consider a more potent drug to deepen the molecular response. We actually couldn't do that in the UK at the moment, but perhaps in the future you could start her back on asciminib or ponatinib. Or we could consider the IVF strategies to shorten the whole process so that when she stops again, we can simply reimplant an embryo and she'd only have to be on treatment for the 9 months. And remember that this woman was 35 at diagnosis. We've got her to MR5. We've tried a pregnancy. We've lost the MMR. So now she's probably pushing 40. So the bottom 2 considerations are more important for her, I think, than the first. So it's an individual discussion depending on the circumstances of the patient. In her second scenario, she starts imatinib rather than dasatinib, and she's rather slow to achieve her ELN milestones. She gets there, but or at least she achieves complete cytogenetic response, but she's not a great responder. We're pretty sure she's compliant, so we press on with the imatinib. And from years 2 to 4, she achieves major molecular response, but this does not deepen to an MR4, making her an ideal candidate for treatment discontinuation. She doesn't have a kinase domain mutation. She's desperate to become pregnant, so we could discontinue the imatinib. We could discuss whether she tries natural conception without any drug, or maybe it starts interferon to see whether she can maintain the MMR. We attempt conception, and if she does become pregnant, we manage that pregnancy and the consequences. We don't have very much information about what happens in these situations, but there's a very nice paper last year from Brazil where they described 31 pregnancies in established CML. 16 were in MMR, but nothing deeper. 8 received the interferon and 8 did not. And 7 of the 8 who were on interferon lost their major molecular response. So you have to understand when you start interferon what you might be trying to achieve. It's not a magical drug. It's not going to maintain a very deep response in everybody. Of the entire 16, 10 of the 16 lost MMR, and 4 of those 10 lost hematological response, but 9 of the 10 regained major molecular response on restarting a TKI. So what we would do, I think, in this scenario is we would change her to a second generation drug. We'd deepen the response, and we'd try again if she was in MR4 for at least 12 months. Of course, we can't guarantee that changing to a second generation drug will deepen the response. In the UK, we would also refer her to our colleagues in the IVF team because we need the time off drug to be as short as possible. Or if the patient has a very regular menstrual cycle and they're pretty sharp and understand what they're dealing with. We have occasionally suggested that they stop their TKI at the end of every menstrual period, that they attempt pregnancy and they do a pregnancy test about 5 days after they would anticipate ovulation. If it's positive, they stay off the TKI, but if it's negative, they go back on it. So if you like, it's similar to drug holidays with patients essentially being on and off for 2 weeks at a time. That's very rare that you can do that. I mean, you really need the patient, the drug, and the situation to be absolutely ideal. So it's not something I would generally recommend. In the third scenario, the patient also starts imatinib, and she's very slow to achieve her milestones, but actually you have a feeling that she's really not very compliant. She has a fluctuating PCR level, never gets CCYR, but doesn't have a mutation. And after every clinic appointment where you read the Riot Act and suggest she needs to go back on the drug, the PCR is better at the next appointment, but worse at the following one. During the pandemic, we lost her to follow-up, and we know she wasn't on drug because she wasn't collecting the prescription. And then suddenly she represents. She's still in hematological remission, but not cytogenetic remission, and she's pregnant. So we would discontinue the imatinib immediately. We had the same debate about whether we would change to interferon or not, but we would support the patient in any decision she made, whether she wanted to continue the pregnancy or not. And we go back to our Brazilian experience. And in contrast to the previous slide, we have 12 patients who were not in MMR, and 4 of these were not in hematological response. 10 of them received interferon, 2 were managed with leukapheresis, and 1 with hydroxycarbamide. It's a very uncomfortable situation. And as you can see from the Brazilian experience, you do run the risk of progression of disease and, unfortunately, death from progression. So what we recommend is that the patient who has CML, who's treated with a TKI, after a period of time will define themselves either as a patient who has achieved a very deep response and maintains that response for at least 12 months, so MR4 for 12 months, or they want to become pregnant at a time when they're not in a sustained MR4. So 2 sides of the slide, what do? The patient who's in a good position, who can stop the TKI as would a TFR patient and stay off it indefinitely. We've been through these scenarios before, becomes pregnant but loses MMR, stays off the TKI until delivery, and if necessary, we can use other treatments in the 3rd trimester. Or they lose MMR, it's not pregnant, so we have the same debate, restart the same or stronger TKI and try again. Much more difficult situation with the patient who doesn't achieve MR4. We can recommend staying on the drug, we can recommend a change of drug to try and achieve a deeper response. We can substitute interferon for the TKI, monitor closely, and if they become pregnant and lose MMR or CCYR, we just have to manage the pregnancy as best we can. I've mentioned referring for IVF to shorten the period that they're off treatment. And in another scenario, we might refer for IVF, create embryos, and if the patient's in a good position, we could stop the drug and reimplant fresh embryos. If they're not in a good position, they've not got a very deep response, we can freeze the embryos, we can push on with treatment. The embryos remain the age of embryos of the woman at the age she created the embryos. So if you create embryos at the age of 28, the chance of becoming pregnant with those embryos will always be the chance of a woman aged 28, even if the patient is 42 when we reimplant them. So in that situation, a luxury situation where you have availability of a good IVF unit, it's a very luxurious position to be in. So all I can say is that we now have quite a considerable experience in the UK. We probably know of about 70 pregnancies in established CML, which, as you can see, have resulted in a range of very happy outcomes. The lady on the left has managed to have more than 1 child, during her time with CML, which is great. I need to thank my very important team back home, and also my three very important colleagues, Elisabetta Abruzzese, Ekaterina Chelisheva, and Mike Mauro, who across various parts of the world have come together to try and promote the awareness and the increased knowledge about maintaining the ability to parent children in patients who have chronic myeloid leukemia, and the wider people, of course. And thank you very much for listening.